Okay, let's go ahead and get started with this afternoon's panel on transforming public health data to support health equity. I'm Matthew Isiogu, Senior VP of Innovation for Contexture. I'm joined today by two of the leading public health voices in the state of Arizona, Deanna Gomez to my right, the director of the Yuma County Public Health District, and to her right, Siman Qaasim, Health Equity Administrator for the Arizona Department of Health Services. Let's start off with a round of applause for our speakers. I'm realizing that I don't have the clicker, so let me find the clicker. The first slide is an easy one because it's our faces. So today in our session, we'll talk a little bit about how public health agencies at both the state and local levels are using health data to support health equity initiatives. We'll hear from our two speakers about some of the downstream impacts that they're starting to see in data analysis that are rooted in some of the upfront definitions of those data elements and then how those data elements are used by their communities. In our discussion, we'll get into issues impacting data on race, ethnicity, language, sexual orientation, and gender identity. All of this with a view to at least two questions. What data does public health need to advance health equity? And then how can Contexture and our stakeholders and participants help to support that vision? Now, in preparing for this session, we talked a little bit about how there can often be a tendency, especially from a technology perspective or an IT perspective, to think of everything regarding data and data quality in really black and white terms. And many of the issues that we'll be talking about today are not black and white, they are not monolithic, they are fluid definitions that change over time and depending on circumstance. So really wanted to say up front that we're hoping that we can have a conversation with the crowd here today this afternoon. We've each limited ourselves to 2 or 3 slides, so it is imperative that we have a conversation with the crowd and have audience participation and questions when we get to that section. So in preparing for today's conversation and doing a little bit of research, I came across some demographic information that I thought was interesting to bring to this group to frame some of the conversation. Now, the original title of this slide was Race is Not Black and White. My wife said that that was too on the nose and was not funny, even for a dad joke. And by the lack of laughter, she was correct. There you go. But hopefully the visual is still compelling. So the visual here is showing a really dramatic increase, an increase of 25 million individuals in America identifying as multiracial as a change from the 2010 to the 2020 census. So we know that, of course, some of this is underlying shifts and trends in population change. But another large component of this is a shift in individuals self-identifying from a single race to more than one race. As we heard from Dr. Stein in the last presentation, understanding individuals identifying as multiracial in particular is important when we hear statistics like teenagers and youth that identify as multiracial have much higher incidences or prevalence of depression in particular. I also wanted to highlight this trend, and this is similar data that's shown geographically distributed. Because if you look at Arizona, the Phoenix metro area, and Tucson below it in particular, and also up in Denver, in the Denver metro area, you'll see that the communities served by Contexture in both Colorado and Arizona are significantly impacted by this particular trend. And so as we're looking to better understand and learn about our growing communities in both states, all of these will be really important considerations for Contexture and our participants going forward. So next I'll introduce Siman Qaasim in a little bit more detail. She started her career in refugee health services. She went on to work in public health for over 15 years, including with the Maricopa County Department of Public Health. After that, she was president and CEO of Children's Action Alliance, which is the independent voice for Arizona children at the state capitol. And she now leads the newly established Office of Health Equity at the Arizona Department of Health Services. Welcome, Siman.
Thank you. Oh, sorry. Okay. So speaking of data quality issues, one is sitting before you today. And I just really wanted to kind of just be a little snarky mom joke, that, that, like Matthew highlighted, more and more is the norm. I think these are my parents. These very nice people are my parents. The woman is my mother. She would identify as white American. My father is from Somalia, as am I, and we would identify as black. If I self-report that data, I'd put black. If someone is reporting that data for me, they probably put Asian. And then here and there, white pops up, and I'm not sure. So you might receive a Siman Qaasim record, and really what's happening more and more is that it's a very complicated reality. So someone like myself, just so you know, I would probably identify as black or a person of color. And so we really have to, there are people, in these data sets, and we have to expand, I would say, the boxes. I experienced quite a lot, I think, of confusion growing up here in Arizona when I came to America from Somalia, and people telling me what race I was and what box I fit in. So I think having boxes that fit people and reality are not only more accurate, but of course, I think doing a great service to our population and especially our younger generation. And then I think, why Matt asked me to join is in terms of how is data being used in the public health context. So in the previous slide, I think if there's one thing to write down, self-report, right? And add more boxes to fit the changing reality and diversity. I think in terms of the use of public health data for folks on the ground, policymakers who are changing laws sort of on high, or practitioners, whether it's a clinician, a public health person, someone that works in health and human services in the Department of Economic Security. In that case, practitioners, the word to write down is co-design. So we want to make, and I'll borrow a term probably from your world, which is, in agile development, you have to get to know your customer, you have to do customer discovery. And I think, and by that you have to get out the building and talk to people. So that's what we were trying to do in terms of creating an Arizona-specific SVI for the practitioners and the policymakers and the community members themselves. So the data points in that data, like myself, and I show up on a bunch of different disparity slides, can have this information to take action. It has to be meaningful for the people who are trying to change data on the ground. So that's why we developed a data advisory committee, and we work with folks, some of you may be on it, and we work with folks from all over the state and rely on them as hopefully reliable proxies or representatives of the end user of that data. That will then get packaged into over to a statistician. We've done some requirements gathering, and hopefully we can create a dashboard that is really relevant and meaningful for people who are trying to work on health equity on the ground. And this is a little busy infographic, but just so you understand from the public health perspective where we are, we no longer look at or think about mortality and then what race or ethnicity is disproportionately impacted, where are the disparities. As you see along the arrow along the bottom, emerging public health practice takes a much more complex and upstream view of data. And so we are wanting all these annoying things like social determinants. What are the conditions in which people live that create the disparities? Institutional inequities, and of course social inequities, and that's where we get to the race, ethnicity, disability status, SOGI, so sexual orientation, gender identity, and those types of things. So we are looking at the public health system in a much more complicated way these days and need much more, I think, complex data. And that's really it.
Yeah, wonderful.
Thank you.
Okay. I'll jump in and introduce Deanna a little bit more. Deanna was born and raised in Yuma. She's worked, is this correct, for the county's public health district for 25 years?
Yes.
For 25 years, the past 10 years as the chief health officer. She was recently recognized nationally by the CDC for her outstanding work leading Yuma County's COVID response. The CDC identified the county and Deanna as really an example for the rest of the country. She's also served as president of the Arizona Local Health Officers Association, was appointed to Governor Ducey to the Arizona Department of Homeland Security Regional Advisory Council, and also serves as co-president of the Binational Health and Environmental Council, coordinating between Yuma County and Sonora. But my favorite of her accolades is she is a fellow of the Flynn Brown Civic Leadership Academy, and that's where Deanna and I met in 2016. So thank you for being here today.
Thank you. It's a pleasure to be here with everyone today. And I'd like to say that all this is possible, all that work, obviously, because we have an amazing team and because ADHS is here and on the stage. I want to really acknowledge the fact that we have an incredibly unique situation in Arizona. And we have a partnership that really is hard to describe to other states as far as public health infrastructure. We have rural communities and we have the urban communities. But when we work together, there's really an emphasis of making sure that really nobody's left behind, because we realize that in order to protect our communities, we have to have a joint and really strong public health infrastructure across the state. The slide you see is a little bit of background of my community. It's located in the southwest corner of Arizona, so we share a border with Sonora, Mexico, and a lot of what I'm going to discuss about is in the frames of COVID. So we share that with Sonora, and that was a challenge again, because again, we live in a country where we're very fortunate, regardless of what your thoughts about the pandemic response, where we had access to testing earlier than most other countries. We had access to vaccines, we had access to data collection, we had access to a lot of that stuff really early on, where our partners in the southern part of the, in the country to the south of us didn't. We share a western border with Imperial County. Now, Imperial County has two borders with Mexico. So they share Algodones and they share Mexicali. So again, and that's an issue because in a community, when you're talking about data, something that people don't take into account a lot of times when we're looking at resource allocation is that we have a lot of United States citizens living on the other side of the border because they chose to do that because of economic reasons, the cost of living, their retirement goes a lot further, and yes, we have a booming medical tourism industry. So we need to capture that data. We are home to two tribal nations, the Quechan and the Cocopah. We are home to two large military bases, YPG and the Marine Air Corps Station. Between November and March, and I think this is something that merits mentioning, Yuma County produces 90% of all the leafy green vegetables in the country. And that is important because along with that comes an influx of migrant farm workers, as well as H-2A visa holders that come and work our vast agricultural industry. So that is important because our population normally trends around, officially, 215,000. That doubles in the winter when you add all those workers, their families, as well as the influx of visitors from the northern states and Canada who come down. So again, those are challenges in data for us because when you're looking at resource allocations, particularly within a pandemic, people are looking at that 215. They're not looking at all of a sudden I have 400,000 people in my community. They're going to need access to these supplies, that are going to access the healthcare system, that are going to need, all sorts of resources. So that is a data challenge for me. When you look at our public health data sources, these are the tried and true. We had the public health dashboard that was, you saw instances of it earlier. I'm sure you're all familiar with that. ADHS did an incredible job of putting that together. We were able to, at a glance, look at lab-reported cases. So we saw the positivity rates. We were able to see the number of cases. We had the Centers for Disease Control, which again, we use those statistics. We see HRSA statistics, and then there's the county health rankings, and that's a partnership with, I think, the University of Wisconsin and Robert Wood Johnson Foundation. But what happens with that data, it's that, with the exception of the ADHS data, is large picture data, and it doesn't capture a lot of the community level data that I just talked about. Then we have electronic health record data. So we're able to, in our county, in Yuma County, we have a unique situation where we actually share our electronic health record system with our local hospital. We have one hospital, and they actually are in partnership with a lot of the local providers, and we all share the same electronic health record system, which makes it really useful as far as sharing data and anticipating things. We have demographic data like vital records, and we have hospital admission data. Then we have our standard surveillance systems that helps us track trends, demographics, lab reported cases, and program utilization. Something that we did during COVID that helped us, particularly the agricultural industry, was the fact that we worked with the University of Arizona Cooperative Extension, and through a grant through the governor's office and through the Arizona Department of Health Services, we were able to establish wastewater surveillance specific to COVID. Now that was important because it was useful, particularly in enclosed environments. You saw it used in dorm rooms. I'm sure many of you have heard about the University of Arizona dorm room study where they were able to identify, you get up to a 2-week head start as far as seeing those trends before you actually identify a positive case. Early in the pandemic with the original strain of the virus, you saw that it could be anywhere from day 1 to day 15, so there was a big gap between you became symptomatic. This allowed us, if you saw increased levels in the wastewater, you were able to test, and you were able to identify somebody who may be contagious but hadn't necessarily shown symptoms. And that was particularly important because at that point with the first virus, we knew that about 70% of the cases were not symptomatic. So that was very useful. It had applications in the agricultural industry because they were able to develop plans, protocols, safety protocols. For example, when they transported people to the fields in the buses, they had seating charts. And then when they tested the wastewater surveillance, and then they did rapid tests and they identified somebody, you didn't have to isolate everybody. So you were able to test those people, identify, and then you knew who was close by in proximity, either working the field or on the bus. And that was something that the CDC was really impressed with the level of safety that they had implemented. But that was very useful because that was a concern. That's your workforce. Then we had town hall meetings, and then we had community health workers who are otherwise known as promotoras de salud, and some of you in healthcare might be familiar with that. And they went door to door. We had town hall meetings. ADHS, for example, hosted phone telehealth type of outreach events. And then people got to ask their questions either through a variety of those phone type outreach events or through Facebook Live. And we took every question. And if you didn't get your question answered, we followed up with you. We took those down and we made sure we answered your questions. We had 2 teams from the CDC come down because we were advocating for resources. We had one hospital, or we have one hospital, and the strain on the healthcare system was incredible. We went from single-digit cases to double digits to triple digits in a matter of weeks, and that put a big strain in our healthcare system. So something like the surge line that you saw earlier was a lifesaver for us because it allowed people that live locally to still have access to medical treatment when they needed it. We didn't want to overwhelm the healthcare system. And then we have other surveys like the Behavioral Health Youth Survey, Risk Survey, and then we have the youth version as well. But again, those, they have limitations. And so for us, the challenge is we know data can be the universal language. We know it could be used to tell a powerful story. But how do we capture that data at a local level? And how do we make it meaningful for the people that are developing these policies and the decision makers? So here are some of the things that we look at. So one of the challenges is the data collection process itself. What we saw during the pandemic is that many people were hesitant to answer questions. They were hesitant to talk to healthcare providers. They had concerns, particularly with a government-aligned organization. And so what we did was we reached out to local stakeholders and community members and those NGOs on the ground that already established the trust. You have those people that you're working with in the community. You need to make sure they have a seat at the table. Sustainability, what we saw was different funding streams come through. And so we would see X amount of money come through, but it would be, by the time you got the funding, it would be, you have 4 months to use it. and then it went away. So we have to figure out a way to leverage that funding so it's sustainable. And if it means having some sort of multi-use, agreement or a memorandum of understanding so that we spread that money out and we help build capacity across different sectors, that'll go a lot further. Data governance and stewardship. For us, it's important. In public health, we're always about guarding your confidentiality. It's important for us. But in order to increase equity and infuse equity into some of these policies, some of that data needs to be detailed and de-aggregated. So there's a big, big need for reassurance as far as that governance and stewardship, that people know that their data will still be protected and used appropriately, so that we can get that and start working towards equity. The relevance of the data. What are you collecting and how are you collecting it? During the pandemic, we talked about we could see how many people in this age group were getting vaccinated, or how many people in this age group were accessing clinical services or having complications. But some of the things that we didn't know were, in our community, there's a lot of multi-generational homes. So when we were giving guidance, if you become infected, please isolate. If you could use your own bathroom, that's great. That's not a reality for some households where grandma lives with you, or you have your great uncle living with you. And you have young kids who we all know get into all sorts of stuff, and they might have not gotten as sick as the adults, but they were bringing it home. And so when you're talking to social determinants of health, you need to capture that data. What is your environment? We were telling people to come get vaccines, but the field workers were going in at 4 o'clock in the morning, and they were coming home at 10 o'clock at night, which meant our staff was going out at 4 o'clock in the morning and going out at 10 o'clock at night. We were registering through a portal that was a good portal, but if you don't have access, which is a reality in a lot of rural communities, or reliable internet connections, you're not going to get on those portals. If your health literacy or your language skills are not, English is not your first language, you're not going to get through those registration processes, which means we worked with churches, we worked with the food bank, we worked with the local municipalities to register people, or actually they registered people, and we just showed up. And so when you look at that, building equity focus into policy development, that means engaging the community, engaging the people. Who is your community? What are their needs? Where do they live? What are their challenges? What we think, and I'll say for me personally, as somebody that's been in public health for a long time, from an academic perspective, I've heard I've heard the narrative, I've heard the data, I've seen all that, and I think I know, and I'm constantly surprised. So invite those people to the table, ask those questions, hear from them. We had something with behavioral health one time where people were not going to their appointments, and we saw a sharp drop. And we were wondering, was it the provider? Was it a difference in coverage? And it turned out that the bus stop near that clinic had discontinued that route. But it took us months to figure that out until somebody said, well, the bus stop's gone, and now I'm not, the nearest. And in a rural community, the bus does not run every 15 minutes. It's an hour and a half, and it's uncovered. So those things. And interpretation, finally. We work, I don't know if any of you have heard the term a chief health strategist or knowledge broker, but that's about working with your community and the different stakeholders in the different sectors and having those conversations to strategize about the direction of the policy, the health actions, the health programming in your community. And knowledge broker. So you have the data. How are you going to share that data? Who are you going to share it with? And now that you have it, how do you create a narrative to share it with people that need it and in a way that's understandable and relatable to them? So those are the things, because sometimes you have the numbers, and if that's not what you're used to, even whether you're a policymaker or a seasoned academic, the people in the community who are making those decisions or applying for those funding sources need to be able to use it. It needs to be able to tell a story, and the best way to tell a story is to talk to the players and the characters in the story and learn from them. So that's my spiel on that.
Wow, there's so much to unpack there. I think just my reaction to what you just presented, Deanna, is we're hearing a lot about a health equity framework and how to not just have that be an overlay on an organization, but to embed health equity and health equity principles in the DNA of an organization. And it's so clear that that's exactly the work that you've done in Yuma County, and what a great example for us. I'll kick it off with a couple of questions, but I'll ask folks in the audience to start lining up between the two microphones on either side, and would really love your thoughts for our panelists as well. A question, Siman, from a state perspective. I'm interested in the Arizona Social Vulnerabilities Index, the Arizona SVI initiative that you mentioned. Have some familiarity with the CDC SVI, but wondering if you could talk a little bit about some of the similarities and differences.
Mm-hmm. So it essentially is the CDC SVI, and if you're familiar with the Social Vulnerability Index, it has 4 different themes that touch on basically different social determinants of health. The highest score would be a 1.0. So a community that had like a 9.8 something SVI score, social vulnerability score, would be very high. So that would mean, you know, high minority population, scarcity in housing, access to health care, and such. So those types of sort of environments. And then really what we're doing is saying, okay, thanks CDC, and thank you for putting it in census tract level data instead of county level. And this is wonderful, but you know, Arizona is different. Just as Dr. Gomez pointed out, there are so many unique things about Arizona. We have 22 tribes, we have a border with Mexico, we have different heat and different environmental things going on, and we are going through, you know, quite a bit of inflation and quite a bit of a housing crisis. There isn't connection to broadband, reliable connection like there should be. So think about, so we invited folks to the table. They are doing other projects too, but they are linked to the community so that we can create, like, you know, Dr. Gomez said, invite the people in the story, not just the community members, but also the people on the ground who are doing the public health or medical or, you know, health and human service interventions. To the table. What is unique about Arizona? What do you really need to make a change that's not in the other data sets that are available? And we have a long list of suggestions from folks and really, you know, compelling information. And housing did really bubble up there in terms of rent burden. And so now we're going to work with ASU Knowledge Center to sort of package, see what's viable and at what geography level. So we also ask folks, like, what's a functional geography level for you? I'm not surprised. The answer was not county, you know, or PCA level data, but really census tract and sub-census tract level data, because people are trying to do things at the neighborhood level. People are trying to make change where they live, and they need small area data in order to do that. So I don't know if I answered the question, but that's essentially sort of what we're doing with the SVI. I will say one thing about SVI, besides the practitioner, we use it a lot as a person, as an institution of funding. So the CDC uses it to give us money. The idea is that, you know, here's a major social problem, here's a major health challenge that is incredibly complex, that takes people from across many sectors to solve. And where do you put the precious resources? I mean, we could spend $1 trillion on each health challenge that we can think of. We don't have $1 trillion. Sometimes we have very scarce grant dollars or whatever dollars to put towards it. And so SVI is very much used to prioritize communities. And that's at the heart of what health equity is. Self-report, co-design, and then look at data to prioritize certain communities. Don't spread it thin like peanut butter across the whole state and think that you're really going to move the needle on something. You have to, you know, strategically go into specific communities, but how do you make that decision? So SVI is something like that. So some real life examples, CDC uses SVI in terms of what money we get to the state. When we ran a multi-million-dollar paid ad campaign that included door-to-door visits from folks in rural counties. We used SVI. We said, here's our top 3 census tracts per rural county. The ads, everything, the geo-targeting has to be here. Why? Because we're prioritizing those communities. We overlaid it with vaccine rate as well, of course, COVID vaccine rate, but it's layering in, right, SVI with different data sets to have a more targeted and strategic approach. Another thing we do, we have the Arizona Health Improvement Plan. And so we look at the massive sets of disparities that come forth in our state health assessment, and then we make an action plan with stakeholders on how to solve that. And we end up, we actually have money. And so we give money to different, folks who apply in terms of solving those problems, and we ask them, it's a requirement in that RFGA, that they use SVI and other multiple data sets to tell us who are you going to work with in the community, and what are you going to do to move the dial for this specific community that is, burdened by a health condition. So SVI has very real resource allocation implications, and it's already being used in that way, I would say, from the federal level down to the local level.
So to pull a little bit on one of those threads, and you alluded to, federal tools, federal policy, availability of funding, and so on. And we heard from each of you some of these federal touch points. I'm interested in your thoughts on, have you seen changes in federal policy, especially in this period 2020 to 2021, now 2022, a change in administration, a change in health circumstances? What are you seeing from a federal policy perspective when it comes to health equity issues that you think are positive trends, and what are some areas for improvement that you see?
I think it starts with having a greater dialogue. And regardless of what your thoughts are on a particular issue, having that dialogue is important. I think we've seen more of that post-pandemic. I think we learned a lot of lessons during the pandemic. It brought forward a lot of inequalities, things that maybe were not front and center to many of us. But again, access to healthcare, access to healthy food, comorbidities, multi-generational housing, access to some of these things, depending on where you were on that spectrum or how many of those issues you were coping with, your outcome was going to be different, all things being similar. And so I think having those conversations and being able to have dialogue again with the people in the front lines, because they see things that most of us don't see on a daily basis. And they have those in-depth conversations with the public. And then being able to share that data. Data needs to be accurate. It needs to be the closest to real time is important, because then you can have an intervention. And a lot of what happened during COVID was as we went. But having that data and being able to communicate, if it's working somewhere, then you share it with somebody else, so that they don't have to make those same mistakes or go through that to figure it out. And they might have to tweak it for their community, they might have to make minor changes, but at least this whole piece of it is already done, and they don't have to spend resources or time trying to figure that out. So being able to share that data and being able to communicate it with the stakeholders. We had weekly, at one point, weekly update meetings with our policyholders and our elected officials. So we had, in our community, we had, the local mayors, city council members, our board of supervisors, but we also had representation from our state, here in the Capitol, representatives, and as well as our federal delegation. So we had our senators, and they, every week, for an hour, we sat there and we had these conversations. This is what the data is looking like. This is what the strain on the healthcare system is. These are some of the initiatives from the state health department. This is what the surge line is. And that was important because we were collecting local data so that when their constituents called them at a local level, they knew they could answer that question. They knew who to connect people to. From the state level, there was a lot of conversation at the state. We were looking at discussions. They knew what was happening at a state level. And from the federal level, because we needed that advocacy to get limited resources, we knew that we needed testing. We knew we needed the large-scale vaccination clinics, but we could answer those questions. And when decision makers have multiple competing priorities and they're getting lots of data, it's important to be able to speak to them with the most accurate, timely data that you have, because it's meaningful, and then they can share it with somebody else. And so you start making those connections, and next time something like this happens, because there'll be a next time, it'll be different, but there's something else, you're better prepared. And at the end of the day, the data and the plans you put in place based on the data will help you be more resilient, will help you bounce back faster. And that's what we want, because that's going to take less resources and it's going to lead to a better outcome, because then you just have to adjust to that particular circumstance.
Yeah, and I'll just share, there's so much happening at the federal level, around some of these principles that we're talking about, such as inviting community members to the table, making data meaningful, transparency. That's definitely coming down the pike. And so, yes, we have to be safeguarders of protected health information. We have to protect communities. We don't want to make them more vulnerable by the data that we share, but we have to find that pathway to yes in sharing more data, more granular data, because again, we need to be able to make decisions based on it on the ground. So for COVID, for example, what is exciting to me is CDC is working with ASTO, state and territorial health officers. Yeah, thank you. Is working with ASTO to really work on with syndromic surveillance data. So thinking about an emerging epidemic. A better definition that's based on codes, the ICD codes for disability. Because census, it doesn't quite hit at the functional disability. And so they are working now on creating a better way to define and to be able to describe folks living with disabilities in our community. We admittedly didn't do a great job at the beginning of COVID. In terms of thinking about the disability. And we're walking that back now, and we're trying to be much more inclusive and to think about those needs. Again, that's an who's at the table question. But for example, I'm still hung up personally on homebound. So let's not even get into how do you define homebound. But folks who can't get a vaccine or other medical services, but thinking in the context of COVID, because they cannot go to a pop-up clinic, even though we thought, wow, we're bringing it to the people. It's here at this school, but someone who cannot leave their homes, but there's no special designation. But there are people who provide services in homes. So how could we how could we break that down to talk to maybe home care providers, so that even if the data doesn't come to us, we can come to them and make sure that they know how to access us, and folks know how we're defining homebound and how they can get a vaccine. But we need to think about a better strategy for folks like that, in emergencies. Yes, we have the Empower data set, but that's Medicaid data. So that hits a certain age population, and of course, dually enrolled with Medicaid, who are very, 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 have a lot of health issues. But I'm stuck. I need solutions for that long term. What we're doing now is to me, seems inadequate, and we don't even have a scope of the problem. Maybe it's not a problem, but we definitely need to be able to check that box and know that we've met those people's needs. And I cannot for the life of me, and I've asked a lot of people figure that out. So this is the kind of thing that we're coming to you guys for solutions.
So if anyone has solutions, know who to talk to.
Please.
So we're talking about how critical it is to have these conversations. But I'll say honestly, from my perspective, I think oftentimes approaching these conversations from the technology, from the data itself, there's not always a common vocabulary with public health or with the social services and so on. And if we don't have a common vocabulary, or I don't know the right words to use, there's a reluctance to have the conversations, and some of these things can go unsaid. I heard you use the term earlier, SOGI, sexual orientation and gender identity, and that's a new set of terms that I had actually not previously heard pronounced in that way, SOGI, that gave me a pause for a moment. So I wanted to get your thoughts on that set of issues coming into these conversations, and especially as you look at partners in the technology and the data space. If we aren't sure the right words to use, but are really open to having those conversations, what are some ways, do you think, to overcome those challenges?
Something in public health that we use, and with, for example, with thinking about promotores de salud or community health workers, but just in general in public health and in the clinical setting with patient-centered care, is the concept of cultural humility. Cultural humility isn't, I can walk into any room of any number of people and I know all the right terms to use and I'm never gonna, get my hand slapped. It's about a lifelong learning process. And so, maybe watching a video or something on what cultural humility is, but essentially it's just ask. When we were engaging with the disability community, I was cold calling, organizations, and I don't know all the right terms. I don't know some of the nuances of the assistive technology that folks use. So start from that place. Ask. Just ask and listen. And one little hint I'll give you is never ever tell people, oh, what are you guys calling yourself nowadays? That's gonna really shut some doors down for you. And don't presume to tell people what they should call themselves. That's also gonna shut doors down. So you really just ask, just listen, and follow their lead. They are the data expert in their lived experience, the qualitative data of what it's like to live in their world. They are the expert there. And so treat them with that respect and understand that they are the expert in that situation. Follow their lead. And honestly, I can't promise, but if you just approach communities, people, your work in that way, organizations you've never worked with, what LGBTQIA, what? If you just approach it in that way, you're probably going to do yourself a big credit in terms of building trust. And you have to have the conversation because when you're not, you're silencing people.
I would agree. I think it's like every other difficult conversation. We have the same end goal in mind. We want to make services more accessible. We want to make the community better. We want to make people better. So the client you're serving and you as a service provider or NGO have the same goal. And like every other difficult conversation, it's easier to kind of just go around it or not have it because you don't want to offend somebody or you don't know what to say. And so I think, again, accepting the fact that it's going to be a difficult conversation you're not comfortable with and just saying that up front, I don't know. But I've been in public service for a long time. And in public service, my job is, it's a life of service. I don't know, but I want to do a good job. And I know in my 20-something years experience that we've had some, what I think are very cool, innovative programs that didn't pan out because they were developed based on what we thought were cool, innovative, solutions or strategies. And you can have the best program in the world, but if people don't know it exists, or people don't feel comfortable accessing it, or it wasn't developed with them in mind, it was just you and whoever, because when you work in a certain field, you see people just like you, right? Whether you're a data person, or whether you're a policy person, or you're a clinical care person, you're usually around your group, and that's who you brainstorm with a lot of times. So bring that, other person, even within your group, that person that normally makes you want to be like, I don't know if I should have that person, because they always bring up this, bring them. Bring them to the table because you want to hear what they say because there's somebody out there that's thinking the same way. And so you want to anticipate some of those things, but just say, I don't know. But I want to learn and I'm going to make mistakes and I apologize in advance because I'm probably going to say, or maybe I should have known, but I don't. But I want to learn and I can't do something about yesterday or the day before, but moving forward, I will know something and I will be better. And it's like building capacity in any other thing. It's like a skill set, we all learn a new skill, a new language, learn how to do something, and you're better every day, that you practice, that you engage in it. But we all start not knowing something or other. And during the course of engaging in it, practicing it, we get more proficient. This is no different, and start by asking the question.
I appreciate especially learning about the concept of cultural humility in particular. Something else that was mentioned earlier was the importance of self-reporting for race identification, self-identification of ethnicity. I think that there are cases where I kind of think about it for a moment from a data perspective, that we may have one individual that we have different data points where race is blank for half of them. There may be black, there may be white, there may be black and white, and so on. In some cases, the individual may have self-reported differently in different contexts. But from a data perspective, there's an instinct to think or believe there's a right answer, and that we can reconcile these different data points to, okay, so what is the bottom line? What is is the race of this individual? Because I know it's important and I want to get this data in the right hands. But I'm wondering if you can talk a little bit about, understanding the complexity of those data points and kind of the additional dimensions that race can be a fluid concept, self-reporting may change over time depending on circumstance. But when you're presented with data sets that have this, then from a public health perspective and even from a policy perspective, how would you like to see that sort of data analyzed and made sense of?
I mean, I think that has to start, like a conversation between people who work more on my side of things and with communities and people who work with data, because I don't think we quite understand the challenges you have in terms of matching data. And so I think if it's really about a two-way safe space dialogue about what is it going to take to move things as they are now to things as they need to be more useful. One thing I want to say, and I'm probably going a little off topic, but race is a social construct. It is not actually real. But the assignment of race, the constructing of race in society has extremely real consequences. And so we have to, when we do all this, we have to not reflexively go into explanations in difference of outcomes based on biological factors. And if you are, for some reason, for example, COVID, we had disproportionate deaths across the country, and especially I'm thinking in California for African Americans. Come to find out, COVID, the respiratory condition, that is how you get oxygen into your system, pulse oximeters were not designed with people with darker skin in mind and are actually inaccurate for people of darker skin and could account for some of that difference in terms of health outcomes. So I know I'm going a little past like how do you reconcile some data sets, but the ultimate use of it has to be, it's really complex and it's everywhere. It's about how we choose race in research. It's about having representative races in when we're developing stuff, tools that can be life-saving or life-changing for someone. And it's about expanding how we're categorizing it. If you ask me, I'd say, please give me a people of color box, or have a lot of boxes that say white and this, let me check 2 boxes, and I don't know what it takes on your guys' end to make that work, but can I please check 2 boxes, and can we just move with multiple data? I'm ignorant. I don't know what that means on your side. I'm probably giving you guys a heart attack. But, that is what I think needs to change for data to match reality. And if we have data that matches reality, then we can fix the real problems and not the wrong ones.
Thank you.
It's going to get fixed here today, right?
Yeah. Come on, guys.
We're taking notes. So a question from the audience.
Yeah.
So I do have to say that I warned this gentleman that if there was not a question, I would call on him by name. So this is a preemptive strike on his part.
I don't have a question. I'm Todd. I'm with Contexture. I was just going to say it's no problem on the 2 boxes. We'll be happy to do 3 or 4. And when our CIO gets back, she'll solve that for you this afternoon. Okay, I just want to let you know that.
I'm glad I came.
I did have a question. Actually, it had to do with capacity. So one of the things we were talking about earlier is, boots on the street, out in the community. When we need to gather the information that is not accessible through normal channels, we go out and get it, right? I come from home and community-based services. That's not a scalable effort. It's something where we have labor problems, capacity, collection issues. There's a million reasons why we struggle with that. And I was curious, is when you were doing that in Yuma, Diana, what were the constraints you were running up against during that time, especially when you have such a fluctuation in your populace that can radically change, obviously, your capacity over short periods of time? I was just curious how you handled that.
Okay. So let me see if I can summarize this right. So the question was the challenges of being able to get the data at the community level and scale it in a usable way to deal with the challenges. And part of it is that we've been working, because we're a border community, we recognize that challenge early on. And actually, the Promotora model, at least in Arizona, started in our health department in a program that was funded by the state health department, actually, called Health Start. So we are very familiar with the Promotora model. So we knew that those Promotoras they literally go out to the fields. And we were out there at 3 o'clock in the morning. We work with the harvesting company, the agricultural companies, so that we address that population. We know we have an influx of winter visitors. We work with the Chamber of Commerce. We worked with the different community centers. We knew that there was going to be a whole segment of the population that were going to be scared to come forward. When you talk about, for me, the previous question about self-reported data, the challenge in that is who's self-reporting? Where are you getting the data from? Because who shows up at karaoke night, right? The extroverted people. Who's more likely to answer questions? Who's more likely to access that service? So when you talk about self-reported data, for me, it goes one step further. How inclusive is that data that's being self-reported? Where did you collect it? Did the people feel comfortable? Because as a healthcare professional, there's certain information, I don't think, probably way too much personal information, that I feel comfortable sharing with a healthcare provider at great detail and length. But when I get those surveys about other things, I'm just like, no, that's, you don't need to know where I shop or what I eat. But I'm really free with the health information because I know I live in that universe, right? That's my reference point. So for us, it was really having those personal connections. And I always say this about public health. We don't have to be, and I'm going to use another music analogy, we don't have to be the lead singer. Sometimes we're in the backup in the choir, and sometimes we're the road crew. And sometimes we get out of the way and we say, look, you've been doing this, you've been collecting this type of data for so long, help us. Tell us what you need. And if we're the people with the clipboards collecting the data, we're the people picking out, passing out the snacks, but they trust you, then we will be in the background. I have no problem with that. What do you need? Do you need to hire more promotoras? Do you need, it was a constant, look, we're trying to figure out, it was giving praise to the people and acknowledging the work that had been happening in our community for a long time. My job now moving forward is making sure that those connections that we made and that help that we got from all those community members, NGOs, public health officials, does not end with this pandemic, that we continue to give them a seat at the table, because that's what happens, right? We don't want to be reactionary. I said about building capacity, and after I'm gone, I need people to still have that relationship and be like, we can call the health department to do this, and they're a source of resource. And within those connections, I found a lot of other little and I want to say non-formal, because maybe they were just starting out, but they didn't have their 501c status, but they were like that lady that goes to the neighborhood and passes out the food to the homeless people in the community, or that person that does this. And so loosely organized volunteer organizations, and we let them be the trusted community member. And so that was a way. And then we had all this data, and we were like, how do we share it? So for a rural community with limited staff, once I had all this information, I knew how to use it. It validated what I already knew. But then how do I share it with the state? Mm-hmm. How do I share it with other partners that might have a similar situation, maybe a community in La Paz or Mojave that's rural, or somewhere else in a border community like Santa Cruz? How do I share that in a meaningful way? Otherwise, I have all this data, and I've used it, but I can't share it, and I can't build capacity. So it's about getting it, what do you do with it, interpreting it, and how to use it for the greater good for somebody else. And I think that's maybe that was one of the reasons I was excited to be here today, because I knew that would be solved here today too. So.
Well, and I'll say, so from the state perspective, we do realize that if you look at the data relationship, there's a lot of pieces of chess on the board. And the people that are in the data sets really just have the extraction purpose. And that's not always okay. And so we want data to be bidirectional. So we're pulling data, and we're sharing it with communities in a transparent, granular fashion, and with usability and user-centered design, in mind, so that they can act on data as well. But we have to build that capacity. Mm-hmm. And so that's part of also what we're doing with the Data Advisory Committee is working with ASU CERC to really come up with a good toolkit for community-based participatory research. I don't know if you guys are familiar with that. It's an old concept. And so that we can get data back from communities, we can give communities, and we're thinking place-based, neighborhood, small sort of place-specific communities, or even identities within a space, but small areas. So the community-based participatory research is not to give you state-level data. To empower them to collect data that's meaningful, that's actionable, so that they can ship it back to us. And by us, I mean state agencies, policymakers, people who allocate resources, who decide where grants go, because we are missing it a little bit with the data that we have. And I think you've kind of picked up that, from Dr. Gomez and I. And so we also have to build the capacity in the community. And so we're trying to experiment with things like that and be very open to any other suggestions as well.
Well, thank you both so much. And from a Contexture perspective, we are so excited to work with each of you as we continue these conversations and build these connections. The bidirectional data exchange is one of our favorite phrases to hear. So appreciate that in this context. If there are no additional questions from the audience, then we're going to do a quick change with the next panel. So please stay here, stay in your seats, and the next panel will join you shortly. So, thank you.